Hi, I'm your host, Juliet, on Connecting the Dots podcast. And today I am joined by two brilliant scientists, one from Kenya and one from Zimbabwe. I'm joined by Professor Isabella Oyier, who is the head of biosciences at the Kenya Medical Research Institute, Kemri Wellcome Trust in Kilifi, and also Professor Collen Masimirembwa, who is doing an encore. He's back again on Connecting the Dots podcast. And Collen is the president and CEO of the African Institute of Biomedical Science and Technology, AIBST, based in Harare, Zimbabwe. And I've literally hijacked them from a conference that is taking place in town in Nairobi, which is the Evidence for Development Conference organized by African Institute of Development Policy, AFIDEP, Science for Africa Foundation, SFA Foundation, as well as the African Union Development Agency, AUDA NEPAD. Now, I'd like to welcome the two of you. Karibuni, Isabella and Collen.
Thank you.
The interesting thing and the thing that you both have in common is that you are both Calestous Juma Science Fellows. Tell us a little bit about what that is first and what that enables you to do. Collen?
So the Calestous Juma Fellowship is really to identify scientists across Africa who are at a certain point in their career development where they can transition to science leaders. And because there's a belief that progress could be partly being hampered by lack of science leadership across the continent. So this fellowship allows you to get protected time during which you can focus on how to engage policymakers and create a pathway for science to prevail and be an agent of change on the continent. And this is what we've been doing over the past 5 years to really see how the science we've been doing can rise to the point of policy change.
Isabella, Calestous Juma, last 5 years, for the next 5 years, as Collen has said, what has it enabled or facilitated you to do that you would not have otherwise been able to do?
I think the Calestous Juma Leadership Fellowship is a great opportunity, as Collen said, for those of us who are sort of nearing science leadership roles to actualize that. And so we've been able to do research and push our research, push our research from the lab or wherever we're working towards policymakers. So it is helping us bridge the gap so that our science becomes relevant in Africa and so that we can communicate that science so that it has impact. I think the gap really was we as scientists are used to talking to our peers. So we use that language. But it allowed us to shift our mindset and say, how do you communicate that science so that people in the public health space, so that a patient in the hospital can understand the importance of the research and it can have impact across the continent or in the areas that we are working in.
So I know we have two Calestous Juma fellows here with us today, but you're a group of 14 people. So collectively, what is it that you've been able to do in the last couple of months or years as a group?
Whilst we have pursued our individual research ideas and developmental paths, we have also come together on several occasions where we have said, what are the impediments to our development and that of our fellow scientists? So we wanted to identify, things that were making research and development or research in general difficult on the continent. And we were also trying to find what can be done to address these issues, both in the short term and in the long term. So we have identified a number of areas, maybe up to 6 areas, where we feel something can be done. And if done, it will improve today's practice, but most importantly, it will project into the future and it will make the path for future scientists better than it has been for us.
And, Collen, actually on that point, now you're beginning to touch at the recent discussion you've had at the conference of what in Africa or African innovations we can do today impacting the future. And maybe, Isabella, do you want to talk about the specific areas we heard you and also your co-fellows discuss? I think there were about 6, a little bit on that.
Yeah. I hope I'll get all 6 right, but at least
I'm sure we can help you.
We touched on product development. We talked about supply chain. We talked about research culture, excellence, and quality. We also discussed data and digital data, or just data in general, and how we use that. I don't think I've mentioned 6, but I think that's about 5.
Yeah, I think
Oh yes,
finance.
and economic financing and
Yeah.
financing. That's right. And the idea behind it was to just bring to the fore, to just highlight that these are the barriers we see that make it a challenge for us to easily do our science in Africa. These are the impediments that make it more difficult for us in comparison to our peers in Europe or the US. And if we can remove those barriers, then those who come after us will have an easier path in the research and development ecosystem.
And, I know we haven't talked a little bit about what both of you do in your different fields, and we'll come back to that. So maybe you could highlight that. But when you talked about impediments, and if we look at researchers on the continent vis-a-vis researchers in global north, in the UK, in the US, there's always this statement that they have a head start. So maybe, Isabella, in the context of KEMRI Wellcome Trust and the work that you do, you can talk a little bit about the work you're doing. And then also in those particular areas, what's different, So
let me just start with the head start. I think I do agree they have a head start, because the research culture is something they've probably inculcated over several years. Yeah. The research institution I work for, KEMRI Wellcome Trust, has been in existence now for about 35 years. In comparison to other universities in Europe or the US, that's short. Yeah. But in terms of what we've been doing over the last 35 years, is just demonstrate that if you invest in people and invest in the infrastructure, then you set yourself up to have impact. So as an example, and the one I gave at the conference, is where we were put to the test was in the COVID pandemic. It came, and we were designated a COVID-19 testing reference lab, as well as a COVID genomic surveillance reference lab. And in the beginning, you think, will we be able to do this? Will we be able to support? We had to support 6 coastal counties, the 6 coastal counties, all the way from Lamu down to Kwale and Taita Taveta. And the question we asked ourselves is, how are we going to do this? But then we looked at what the resources that were around us, and we said, actually, we can do this. We do this routinely for a small research project, whether we're working on malaria or respiratory syncytial virus or influenza. And we said, how do we just scale this up? Because this is now nationwide. And so when we looked at the resources, we looked at the human capital, we realized we had well-trained human capital. We had the IT support, which is the background support. We had the supply chain support. Nice. And we essentially had the ecosystem. We had the equipment and the system for how to get that sample from the field, from the county government teams to us, and to get the result out to the Ministry of Health here centrally in Nairobi. So the system was set up. We just had to utilize it and activate it. So in that sense, that investment over the last 35 years paid off when it needed to. And that's an example from my research institution. Yeah. And that's the case for other centers across Africa that did respond in the pandemic.
Yeah. That paints a really hopeful situation, because, and this didn't happen only in Kenya, even with the Omicron, for example, and the discovery, was it in Botswana?
South Africa.
Botswana, South Africa. It was because of the people, the capacity that they've been trained, and then the infrastructure was existing. Isabella, a little bit about what you do.
So my main research interest is in malaria. I look at malaria genomics and thinking about how we can move this genomic surveillance tool in COVID speak, because everybody was a scientist then, is defining those variants, defining these important malaria, anti-malarial resistance variants, and informing the Ministry of Health on whether we have them in the country or not. So what I'm working on is taking these malaria genomic surveillance tool across Kenya, the malaria endemic counties, working with health facilities at primary healthcare level to collect dry blood spot samples, bring them to a central lab. We can then genotype them and tell you whether you have a drug-resistant variant or not. Yeah. And that will inform treatment, malaria treatment policy, whether the drugs we have and we're using are working. And if not, then what do you do? And can you target your malaria control interventions where we're identifying these malaria variants? So that's not been happening at scale. I've been doing that for several years in Kilifi.
Yeah.
So my research has been focused in Kilifi. But because we have this problem across the Horn of Africa, from Eritrea all the way down to Tanzania, we need to keep this monitoring. We need to be able to count this problem across the East Africa region so that the countries can respond appropriately. Because antimalarial resistance is a problem. If you have these variants, you will not clear the parasite, you will not resolve your fever, and the malaria infection can become severe and you can die.
Yeah. And, we had you in the conference say a very interesting fact. I think we've also covered it before, that was it one child dies every minute. And why do you feel that policymakers are not listening? I know you work with the government national malaria control programs, but do you feel that there's no urgency from government or policymakers? And did you feel like in this conference, maybe you were given a path to be able to engage them and be able to move the needle a little bit on that discussion, policy engagement, essentially?
Yeah. Maybe I just take it back again to the COVID pandemic. What was the impetus? Is that we had a global pandemic that affected everybody. And yes, I guess there was a lot of financial investment at the time when people had to respond. And then when it all goes quiet and COVID wasn't a problem, everyone's gone back sort of to base or the default setting.
Right.
So if I take diseases like malaria or pneumonia, where children are dying every day, one needs to ask ourselves, how do we cause that alarm? How do we cause that sense of urgency so that people can see that if we deal with these day-to-day health problems, we set ourselves up well for the future.
Right.
Because then we have a healthier population and we have healthier children who then become the future leaders. I think it's around the packaging. I'm not quite sure what we've missed.
Yeah.
But you'd have thought that, children, mothers dying every day should be a public health pandemic in Africa on a daily basis, and we need to respond to that. I guess it might be the packaging, and also potentially from the pandemic, it was just understanding that you needed political will. So even though we are pushing from the bottom, you need political will to want to see that change, to want to see a healthier African population.
And, I like that you're talking about the packaging. And Collen, I want to come to you. In the packaging, we were earlier during the break giggling together about how scientists attend all these big conferences, and it's the way they present the information. And you get so excited because there's a lot of discoveries. I mean, Isabella has been saying about, how they quickly adapted during COVID. And you could see that, oh, wow, we have the capacity. But no one looks at what she has to go through to be able to get, whether it's reagents to use in the lab, whether it's the equipment. So, Collen, for somebody based in Zimbabwe doing groundbreaking research in drug discovery, what challenges, let's not paint the rosy pictures, but what, hoops have you had to jump to get to where you are today? And what changes are you seeing that are going to, catapult you forward, or even other researchers coming up?
So thank you. So being in Zimbabwe is particularly unique in the sense that we have other extraordinary circumstances where the country has been under sanctions for over 20 years. And people underestimate what that means in terms of global interactions, which have been severely limited. And it affects all the way to the researchers who can partner with them for research, who can fund the research they do. And that sort of exaggerates or amplifies the challenges we face. And these are normally in the areas of funding for R&D. Initially, I thought that there was no will by the government. But when you actually go to the different department governments, you can see that even other simpler public health matters are not being addressed. And you are there now asking for support to do this cutting-edge research. You start to realize that is a big ask.
Yeah.
Then for the way we have looked at it in Zimbabwe is to get goodwill from the government, even if there's no financial support. And indeed, we ended up getting that type of support in terms of procurement, where we are able to procure things in an easier way in terms of the taxes that are paid and so forth. But still, the challenge is where to get the money to buy the equipment. The investor hesitates to support things in an environment they think is not going to have a return on investment. So research has remained a charitable activity.
Yeah.
And one of our fellows, Yaw, I think you get to hear him speak.
Yeah.
really wants there to be a shift from R&D being a responsibility of public sector to being a responsibility of the private sector. But for that to happen, there must be a good private and public sector interaction that is supportive of the R&D so that the products that come out of that exercise are part of the sort of return on investment to the country, and employment can be increased, profitability can be experienced. So for us, what ended up being the challenge is the universities not being able to train the scientists sufficiently because they are poorly equipped. We managed to create a well-equipped laboratory where we have been able to do cutting-edge research just to prove that even in the most limiting environment, we can end up doing research which is as good as can be done anywhere else. But really, so that when the COVID pandemic or even the HIV challenge was there, I remember very well in the early 2000s, we were able to use our genomic platforms to start doing DNA testing for HIV, determining viral loads, because that was the country's need. Whereas our private need was to do drugs and diagnostics for other things.
Yeah.
But we quickly adapted our platforms to answer what the nation needs. And this goes to what was raised at the conference, that sometimes there's no alignment between research activities which are externally funded and government priorities of what they want today. And that misalignment builds mistrust and lack of support.
Yeah.
So I think we have all recognized from this conference that going forward, we need to have this alignment. And then number two, the barrier of procurement came to the issue where the cost of research or research and development is 5 to 10 times higher for African scientists. Not necessarily because of the government, but because if you are going to buy a piece of equipment, the price you pay is 2 to 3 times higher than the one paid by your counterparts in Europe.
Yeah.
And then to ship and install your piece of equipment in your country attracts other costs.
Yeah.
So that's one aspect, that the cost of research is high. Then the second one is that the time to get those reagents, whereas other people can order a reagent in the morning and they'll get it in the afternoon or the following day. For us, you have to think 3 months, 6 months ahead. So you are less agile in terms of directing the way your research is going or to respond, because you will have bought reagents for 2 years, but maybe you don't want to go that route anymore.
Yeah.
You are constrained. So these are some of the kind of challenges. But we, as Calestous Juma fellows, we said, let's identify a problem and propose possible immediate solutions, whilst we worry about long term. So in terms of procurement of reagents and equipment, we are asking ourselves, of the 10 or 20 top things we procure generally, what can be made locally? What can be manufactured locally?
But is there anything that can be made locally? Do we have
there's a lot of plastic where people are making all these bottles for Coca-Cola. So there are people who do molding of plastics. So it is a question of those same platforms can be used to make plastics for the lab.
Like Petri dishes.
They are buffers, solutions, which all these people with masters and BSc degrees should be able to do.
Yeah.
So we are turning the challenge backwards to ourselves and sort of think that, and then demand support to be able to reduce the number of things we have to take from outside. And when it comes to a major issue of equipment maintenance, because most of the equipment we use is high precision equipment, and most of the times we have to bring engineers from Europe.
From outside,
And we need to say, how can we train our engineers to be able to service our equipment? So those are the problems and the accompanying immediate problems, whilst we think of long term, because it's going to take time before we manufacture a mass spec, but surely we can manufacture 50% of all the consumables.
That's right. Yeah.
That's how I think.
It's interesting. Even in our very own Kenya, sometimes if you get sick and you end up in some of the hospitals, and depending on what the test is required, we've had instances where they will say this has to be shipped to South Africa, where they have better equipment than even countries like Kenya. And you wonder, I mean, for a population of 40 plus 50 million now, you mean we don't even have an equipment to service, for ourselves. On the point of misalignment and also actually on maintenance, let me move a little bit away from the misalignment one. If I was a young person listening to you, and I'm thinking about a business startup, and I'm like, hang on a minute, did he just say I could develop, if Coca-Cola can create a water bottle for water, and I go and develop a petri dish, are you saying that there's market for me to have a startup that then I can supply a research institution? Isabella, can we sell those to Kemri Wellcome Trust,
For us, it would be amazing because, as
Really?
Colin said, it would be next day delivery. That's what we want. And then you can be agile and start chopping and changing your experiments accordingly and be competitive with your counterparts abroad. The challenge is you do the orders and then you have to wait 4 to 8 weeks, then 6 months for those. I call them basic gloves. We're going very far. Gloves.
Yeah.
I call them basic. They
Are
need
we
to
shipping
be.
gloves?
Well, it depends. If you're hypoallergenic, you might not get them in country. So
What is hypoallergenic?
because you're sensitive, your skin is sensitive, so there are different types of gloves. We need to be able to produce those en masse, and it's also the quality around it, right?
Yeah.
Because you want to make sure that it's not very porous. So those are examples on the plasticware that he's saying that we should be producing on this continent. And I guess, to come back to that point on return on investment, people keep saying we do research and we do it for years, looking at malaria, or years looking at pneumonia. I'm like, yes, we have to do it for years, but the return on investment I can't see how this is not a selling point, that you have a healthy population that are viable and that can work.
Absolutely.
I mean, if that's not enough for the continent, then what is?
Yeah.
So you have to invest in research because the work that we do cumulatively makes health impact. But individually, if we tell you what we do, I'm like, oh, well, what you've done this year won't have impact until 10 years later. But if you compile all the research scientists' work over the years, I'll give examples for malaria, the bed nets, the indoor residual spraying. A couple of researchers do it. Cumulatively, you see the effect, you roll it out en masse, and you have a protected population. So those sort of interventions need to be homegrown in one way, made easier to be done, and then you'll have impact.
Collen?
But Isabel, I think when I listened to, yesterday I was talking to some economists, and they're saying if somebody has a couple of millions and there is real estate investment, which will give him a return in a year's time.
Yeah.
And you are there, you are trying to come up with a vaccine for malaria, and you tell me there's 10% success at each stage, and it will probably take about 5 years before I get this vaccine. The investor is likely to go with real estate and things like that. The question is, I'm trying to figure out how have the global north managed to find investors who are willing to go the long-term investment, which takes longer, and still feel it's worthwhile.
Yeah.
Because here, I'm thinking about the few billionaires we have around. If they are given this scenario, would they fund us?
Yeah, can I come? Yeah, so just to speak to that, even before you get to the vaccine, though we know the importance of vaccines, just think about the diagnostic test.
Yeah.
Wouldn't somebody who's local want to know when they get to the health facility, I have malaria and I have it for sure, because you have a rapid diagnostic test that can do that. You will then get the right treatment and you'll save the healthcare system a whole lot of costs for guest work and this drug, that drug. Or if you had pneumonia, you want to be able to detect that accurately. So they're diagnostic tests. So that's where, I guess, like you're saying, it's about how you envision health and health products towards economic development. And maybe we've not envisioned that just yet. And that's why you think I'm going to invest in a house or land because I'll get a higher return on investment. But in the long run, it's all a cumulative piece. So when in the meeting, they were discussing about economic development and we were talking about all the high-end things. For me, I was like, well, actually, if you give your communities good housing, piped water, clean water, power, you've removed half, actually 80% of our diseases.
Yeah,
and I give you the example, Kilifi.
Yeah.
In Kilifi town, you live in Kilifi town.
Yeah.
Kilifi has a lot of malaria. You live in Kilifi town, you get less malaria than if you live 20 kilometers down the road in the rural area where you're probably living in, in a house that's either a tin house or a mud hut house. and you don't have access to clean water or power. Because the interventions, you can't quite implement them, whether it's a mosquito net or you can't see the mosquito on the wall when you're spraying it because it's blended into your mud hut wall. So there's a simple difference that if you're living in an urban area versus a rural area, you've already made the people living in the urban area healthier because they're not getting malaria or they're not getting dengue or they're not getting any other disease.
And what you're saying actually makes sense to many years ago, we did a model of different companies and see which ones were providing diagnostic tests and antiretroviral drugs to their workers. And we were comparing the absenteeisms in the company and the loss of workers that will have occurred from death over a certain period.
Yeah.
And we then give this information to the CEO. Suddenly, it stops being an act of compassion, but it becomes a business proposition.
Yeah.
Then the company realized that, no, if I pay for the CD4 counts, the viral loads, and the HIV drugs, in particular for those who didn't want to go to the PEPFAR public platforms, they realized that actually they gained more because absenteeism reduced and the death of maybe very senior people in the company was less. So some companies then had internal programs. Right. So I think it is how we are presenting it as a business case. We are presenting it as a compassionate issue where if you intend to go to heaven, this is something that can take you there. Instead of thinking that if you want to make a good business, this is the way to go.
Right.
So I'm beginning to also see that there is probably hope as we evolve our thinking in terms of investment and in terms of why we are into health. We are not necessarily into the health for the sake that it is good for people to be healthy, but it is economically
it's economically sound.
Yeah. I mean, and it sounds like you're already a businnesman, Collen, and you know, you mentioned that actually. You're saying many people do not like business people, but you've had to become a businessman. And what were the challenges? Because I know over the last couple of podcasts that we've had, it's become very interesting. The business of science seems to be a resounding theme that as researchers, and especially as researchers on this continent, we're beginning to be forced, as you become a science leader, you're almost being forced to start thinking about it as a business and how the return of investment, how you can make it better for the younger ones coming up the pathway. So, Collen, maybe to hear from you. And Isabella, also the heart that you wear in Kilifi as a leader, you know, and the challenges that you're seeing and how science can become a business for the community, as you've talked about, you know, the economic returns, even from a government perspective. It would be good to hear your perspective. Collen?
As a business, when you look at the market,
and by the way, you're dressed like a businessman, not a researcher.
Thank you very much.
You should be wearing a lab coat, but
thank you. Yeah. But as a business, you start to learn. I come from a basic lab science, you know, genomics and therapeutics. But when you start to think about the market, you start to think about potential investors. You start to think about how much money do I need to have this business running, and how do I bring people on the table with this type of money? How am I going to return that money? You start to realize that there are people who have been looking at African setup with hesitance in terms of putting their money, because you are asked difficult questions like, how many people are on medical insurance or medical aid in your country? And most African countries is less than 10%, where if you have a product and it is used by a patient, you are guaranteed of getting your money.
Yeah.
Then after that, there are people who are paying from out of their pockets. They will only pay what they can afford. And if you look at the income levels across Africa, they are not the best to think about selling and getting a profit. They will just buy the medicine when they really, really need it.
Yeah.
And then you have most people who don't even go to the hospital. So the question is there a thriving market for the products of our innovations in the current economic environment? And we have seen it for our product, which we registered in 2017. And to do that particular test, you need maybe around $50. And actually, most people cannot afford. So we have not been able to get direct income from the test itself, deploying it to the general population. We are trying to get the income from doing research that uses that product. So we are actually having to create the problem and solve it and then get paid.
Yeah.
So I think that it is important for us to think about the market. And I think it has made other people start to think in the initial stages, why don't we come with innovative products of global importance?
Mm-hmm.
Where the finances can be more reasonable. So we have found ourselves starting to look at creating huge databases which we can interrogate. And our sort of strategic idea right now at my company is that the African genome is so diverse.
Yeah.
What it means is that if you are studying a certain process, the variation in the gene that influences that process, it will have more information because it has many different forms. If you go to European populations, for the same stretch of genetic information, you have only 2, 3 few variations. So they are not able to interrogate. So we are saying if there's a target for cardiovascular disease or so, we are saying we have something you don't have.
Yeah.
So let's come on the table and invest, and we can come up with a solution which is good for you and it's also good for us. So we are starting to think globally rather than just locally. And so maybe we do some kind of Robin Hood model where as we try to strengthen our local economic setup, we reach out to global sort of market. So this is what is happening, but it doesn't go very well with the alignment with national objectives, because national priorities are based on public health.
Yeah.
Where they are saying, which is the top disease? It is malaria, it is HIV. And that is not a problem to Sweden.
Yeah.
But if you find a solution for these ones, no one is going to pay you. So we are trying to be to come up with ways of making it, financially viable, and I think it's possible.
Yeah, I mean, I think our African leaders need to think about things a bit differently. And sometimes we've heard even during this conference about the African Free Continental I think it's the Africa Continental Free Trade Agreement, and just making sure that we're selling products to ourselves beyond our national boundaries. If you think about it, the US...
But there's sometimes the unit of the poor.
Yeah.
It doesn't sometimes solve the problem.
Yeah.
You can, like I was been thinking about the SADC region.
Yes.
Because when I write all this business pitch, I try to sort of say SADC is 16 countries, a total population. But what I should be saying is that what is the income level of these people?
Yeah.
And their capacity to purchase whatever comes up. But you don't want to put it there because it will all scare the investor, so to speak.
No, and I mean, even when you say that, both of you, one of you made reference to real estate. And even when you look at income level of people, there are quite a few or a number of people who have gone ahead and purchased a house. Surely, if I see return on investment on investing in research, and I know I'll get something because there's a young researcher thinking about even developing something as simple as you've made it clear, a petri dish. And you know that this guy, all he needs is a capital of, it's not even the amount of a house.
Yeah.
If you put investment on him, but there are X number of research institutions in the SADC region.
That's a good point. That's a really
I think we should set up a business after this podcast.
You're a businesswoman.
Julia, just a point on what you're saying. I agree with that global outlook, thinking about products for, the world. Let me just come back to malaria. We have about 200 million cases of malaria every year. 200 million, yes. If you make a drug for malaria, Kenya, maybe you make it and you can make it cost effective because your country has supported you by reducing the cost of production.
Yeah.
So it's 200 million and infected people. You can charge it maybe at 50 shillings, 10 shilling profits times 200 million.
And by the way, 50, you're saying 50, that's like 25 cents US dollars.
I mean, think about it. What do they do with the M-Pesa? How much money do they make every transaction?
That's right, yeah.
But now I'm telling you, I have 200 million malaria cases. How many HIV cases? How many pneumonia cases? There is a business case there, even just for treatment and for diagnostic tests. So you can even make, I know with the pregnancy test, about 100 shillings, you get them over the counter, right? So if you made a malaria rapid diagnostic test, 100 shillings, 200 million cases across sub-Saharan Africa, I think you've got market.
Yeah. We have a part 2 to this conversation, and we will quickly rotate chairs and invite the next two fellows. I'm not kicking you out, but I'm just saying let's hear from two different individuals from Ghana as well as South Africa. Thank you so much, Isabella and Collen. Parting shots?
I think from the meeting we have just attended, there was a sense of optimism that whilst the problem remains big, we have demonstrated in different areas, digital health, diagnostics, drugs, that some of the fundamental capabilities and infrastructure have been demonstrated to be able to work on the continent, but they need scaling to meet the size of the problem.
Yeah.
So I think we left with a sense of optimism, and there was also engagement of really the stakeholders. We need to be in the room. Unfortunately, industry was absent, and I think one of our colleagues, Yaw, will speak to that.
Yeah, I like that. You're handing the baton over to him. He has an assignment. Isabella.
Yeah, just optimistic as well. It was great to see the alignment across. Usually we're in our research as a kind of think, oh, we're the only guys who think the same.
Yeah.
But we had people from the policy space, people who are bridging the research to policy space. And it seemed that within this meeting, everyone is aligned. Challenge will be, it's the doing. I think because the brain power is there, the people are willing, but how do we get it done? I think that's the big thing for me. So what are the actions that will move forward so that we can actually get it done? And science, technology, and innovation makes the impact it should be making in Africa.
Yeah. I mean, thank you so much for your time.
Thank
you.